Hello, everyone. Good afternoon and good evening as well, in perspective for the time differences for everyone. My name is Fady Gerges. I'm a cardiovascular imager and clinical cardiologist from Egypt, based in UAE. I'm very happy and pleased to be on board with you in the second EAC Congress, which is being done online, virtual, due to the conditions. We will have live session in our Congress today. The title of the session is Heart Failure Management, Perspective and Limitations. First of all, I'm very pleased and honored to have my friends and my colleagues. First of all, Yasmin Rustomova from Azerbaijan. She's our co-chair and moderator. She's a very close friend, as well as she's a vice president of the EAC board. Yasmin, how are you?
Hello, Fadin. I'm happy to see you. And I'm very sorry that we can't meet in person, but hopefully maybe next year, who knows, we can do our Congress online. But thank you very much. Thank you very much for excellent organization. And thank you very for this session.
Thank you very much. Thank you. I'm very honored to have our presenters today. They are very eminent professors and lecturers. My dear friends, Alexander Nossikoff from Bulgaria, Dr. Nauman Ali from Pakistan, Dr. Sarah Moharem from UK. I'm very pleased to see you all today. Welcome to the second EAC Congress. We will start now with the first lecture, Dr. Alexander Nossikoff from Bulgaria. It will be our first lecture today. It will last around 13 minutes. There will be an open window for questions. Moderation will be there for you for all the questions. First lecture for Alexander, it will be about heart failure and AF rhythm rate control. You can go ahead, Alexander.
Thanks for the honor being invited to your Congress. I'll go through my slides quite quickly because I don't have a lot of time, so I need to finish within 10 minutes. You all know that atrial fibrillation begets heart failure, and the opposite is also true. A lot of patients with heart failure, they do have atrial fibrillation. It's probably about 20% of patients with heart failure have atrial fibrillation and vice versa. So we have a new guideline, DSC guideline for atrial fibrillation 2020. As you see here, if we have HFpEF or HFrEF, nothing is mentioned of HFrEF, but we usually treat it as HFrEF. We can use mainly amiodarone. In my country, dronedarone is not available, and sotalol can be used only in selected patients, usually in the ones that have ischemic heart disease that is resolved. So in most of the patients with heart failure, we have only one drug that we can use, and you see here 1A indication for amiodarone. Dronedarone has 1A indication as well, but in patients with mildly impaired and stable LV function, and the other drugs usually cannot be used in patients with heart failure. So depending on symptoms, and if the symptoms are AF related, and if they can be controlled by drugs, and if the patient has different preferences, we have favoring factors prevailing for rhythm control. And we have two types of rhythm control. One is achieved by antiarrhythmic drugs, and the other one by pulmonary vein isolation. We usually use them both together. We don't use them separately. And you can see here the factors that favor rhythm control. If you look at the guideline, there is one main recommendation for rhythm control, and it's just for symptom and quality of life improvement in symptomatic patients with atrial fibrillation. And in all patients, we need to consider the patient choice, and we need to consider if the patient fails the drug therapy and if the patient is symptomatic, and of course, what's the patient preference. Now, if we go back to the trials, trials of heart failure and atrial fibrillation. There is a small AA-TAC trial. There is a problem with this trial, as with most of the similar trials, that it's open label. It's very small. We have about 100 patients randomized to catheter ablation and amiodarone. And if you look here, that's not the typical patient with AFib that you have. So average age was 62 years. It was mainly men. The BMI was not extremely high. There was not a lot of hypertension. At least in my experience, my patients have much more hypertension than that. Not a lot of diabetes. Quite unusually high amount of coronary artery disease. So the trial was positive if you look at lateral arrhythmia-free survival at 24, 27 months. And it was positive for hospitalizations as well. And the LV ejection fraction improved more. We have another trial, which is CASTLE-IF, and you see very, very impressive primary outcome reduction. So this was extremely impressive when we saw it. Again, it's heart failure patients with low ejection fraction. All-cause mortality was reduced as well. But this trial has a lot of problems. Again, the age is 64 years, so not the usual patient that you see. Mainly male. The BMI is not so high. It's mainly patients with persistent and paroxysmal, very few with long-standing persistent AFib, and LA diameter was below 50. Most of the patient had CRTD or ICD. Again, the trial was open-labeled, and they used modified intention to treat, and they excluded patients who died or withdrew during the running periods. And this is a slide of Milton Parker, and the problem is that because the enrollment was very sluggish, there were significantly more patients in the control group with ischemic heart disease and diabetes, and more with digitalis therapy. So the control group, if you look at these variables, was at much higher risk at the start of the trial. Now, if you look at the patients that were lost for follow-up or were missing, or the data was excluded, again, we have much more patients in the ablation group that was lost. And because the trial was very small, if, for example, these patients had died, this would affect the results. And when you lose patients, you quite frequently lose them for follow-up because of events. And if we consider that, then the p-value will no longer be statistically significant. They used definition of symptomatic patients, but it's very difficult to say if the symptoms are due to heart failure or not due to heart failure, due to the AFib per se. And what was very weird is that they screened 10 times of patients compared to the randomized patients. So they randomized only 1 of 10 patients screened, and I don't think they have ever published the exact criteria they were randomizing these patients. So CASTLE-IF is a very impressive trial, but a very problematic trial to be, it's not applicable for the general population, and there is a recent analysis of a large database in the United States that only a small number of patients met the trial inclusion criteria, and the ones that have met the trial inclusion criteria had significant benefit from the treatment. So if you are the patient from CASTLE-IF, whatever that means, then you'll benefit from this treatment, but it's difficult to find this type of patient. Do not forget that there is one negative trial as well, AMICA, which similar to the previous ones, there were patients with low ventricular ejection fraction that were randomized to PVI and to best medical therapy, and there was no difference in the improvement of the left ventricle at follow-up. Now, Cabana was a trial that all the EPs were hoping that it will show a mortality benefit. This didn't happen, and they changed to show more benefit. The authors, they changed to post-hoc on treatment analysis. That's problematic because, for example, if a patient was on drugs and patient was fine for many years and then received ablation towards the end of the trial, then the entire period of benefit of drug therapy was ignored in this case. There are other problems with Cabana as well. The primary outcome was modified. So initially it was overall mortality, and then they moved to a composite of death, disabling stroke, serious bleeding, cardiac arrest, and this was done mid-trial. There was high crossover rate, 27.5, and when you see such high crossover rates, this is always problematic. It doesn't matter what statistics do you have, but that's problem because the benefits of treatment are diluted. There was a pre-specified subgroup analysis of heart failure patients, and you can see that the rhythm control is much better in this heart failure subgroup within the Cabana trial. In this heart failure subgroup, 60% of patients were with persistent AFib, and the primary endpoint and the mortality were reduced in this subgroup. But this is just hypothesis generating, and we need large RCTs to confirm these findings. And I'm going to my conclusions so we can have a discussion afterwards. In my opinion, there is a selected group of patients with heart failure who benefit from rhythm control, both in terms of symptoms and AFib burden, heart failure severity, and maybe even mortality. The question is how to best identify them. And I don't think we have the right tools at present to identify this group of patients. So what I do in practice, and what many of us do in practice, we load the patients with amio, we do a trial, DC, we cardiovert the patients, and then we try to assess, whilst they're already on optimal medical therapy, we try to assess if their symptoms improve, if their LV improves, and if they're able to maintain normal sinus rhythm. If this is the case, then yeah, we can consider PVI because maybe it can get us rid of the amiodarone, maybe not. There is one selected group where always normal sinus rhythm restoration should be pursued. These are the patients with tachycardiomyopathy. But if you think about the tachycardiomyopathy, you never know that it's tachycardiomyopathy before restoring normal sinus rhythm and seeing the dramatic improvement in the LV ejection fraction. So again, you have to give it a try and then just see if it works. Do not forget the 4S scheme and look here at substrate severity, atrial cardiomyopathy, atrial enlargement, dysfunction, and fibrosis. And here you have to be very careful because left atrial diameter does not always correlate with left atrial volume. And keep in mind that there are patients with small atria where you have a lot of scarring and a lot of fibrosis in the atria, and you can see these on CMR or on electrical maps, but you cannot see this on echo unless you do left atrial strain or some advanced technique. So it's not always about size or diameter or volume, and patients with large atria who do not have so much fibrosis or scarring. So we'll have more and more of these patients, elderly women, not the ones that I showed you in the trials, younger male with lower Charts-Fast scores, and we need to find the best modality how to treat them. When I was starting cardiology, age above 65 was considered a contraindication for ablation of atrial fibrillation. Then we moved to 70, then we moved to 75, maybe we'll move to 80, maybe we'll have newer methods. Thank you for your attention.
This is very interesting, Alexander. Thank you very much for this innovative lecture. And I believe there are very important points that you highlighted, which is the weak points or the pitfalls in those very famous and outstanding trials. Whatever it was, the Amica, Cabana, Castle AF, attack. The thing that you've highlighted very well about the problem with the age limit, the BMI, the weight of the patient, and even the lack of gender distribution. Like I said, one of the studies, they had a very lack of balance in the age distribution and gender distribution as well. Plus the control group, they were very much at higher risk in those some of those trials, like the Castle AF. So it's not like a fair distribution or not like a fair game, like you said. The thing which is very pity, like you said, there's only one drug, which is a class 1A indication, or AF with heart failure. And this is quite a pity, because you can know that many patients in our clinical daily practice, they cannot tolerate amiodarone for some or other reasons, like drug interactions, adverse effects, some thyroid issues, interstitial fibrosis, corneal obesities, and some patients cannot even take some antibiotics when they are taking the amiodarone. And you have to change the dosage all the time, especially with patients who are on VKA, warfarin. For example, those patients with prosthetic valve. So it's a real pity. And I think in those patients, just like you said, that we have to opt for another thing, which is we have to just give it up and go with the rate control, or either we have to go to the catheter ablation. And the thing that in order to do a catheter ablation, you have to do cardioversion for the patient as well. I mean, whatever it was PVI, but you have to also restore sinus rhythm. So I think it's a bit tricky. Do you have any comment on those kind of subsets of patients, AF with heart failure, and they're not tolerating amiodarone? How can we go on with those patients?
Well, I think the only way dealing with these patients is to do PVI. Nothing else can be done, but keep in mind that even if you do PVI is just reducing the burden of AFib. It is not curing the AFib, so it's the problem is not solved. And we actually do not use PVI or cardioversion or amiodarone separately. We always use all together. So what we do, as I said, as a step-by-step approach, is we usually do a cardioversion to see if the patient improves, to see if the LV improves. If the patient doesn't improve and the LV doesn't improve, what's the point of rhythm control then? We do this as well to see if the patient is able to maintain the sinus rhythm, and usually then we do the PVI. It's not so common that we jump to PVI from the start. Of course, we do it in some patients when we are sure that we have tachycardiomyopathy, but how can you be sure that you have tachycardiomyopathy before restoring normal sinus rhythm?
You're right, because you have to see the great improvement first, like you said. And then you can really decide if it was tachycardia-induced cardiomyopathy or not. Perfect, excellent. Dear Yasmin, do you have any comments or questions to Alexander? You are unmuted, I think. Can you unmute, Yasmin? I think you're muted.
Oh,
Yes.
I'm sorry. I'm sorry. No, I don't have any questions. I thank Alexander for a very nice presentation, because I know that Cabana trial is really very difficult trial with all these patients going from one branch to another branch. It's difficult, but thank you very much for a nice presentation. I like it very much. Thank you. Dr. Fady?
Yes, Yasmin, you
Are we going
can
to
go ahead and present, Dr. Nauman.
Okay, yes, and we are going to switch to another presenter, which is Dr. Syed Nauman Ali from Pakistan. And we thank you very much for the presentation. We are going to talk about, he's going to talk about the novel pharmacological management of heart failure. Dr. Nauman Ali, the word is yours.
Hi everyone, I am Dr. Nauman Ali. I am working as Assistant Professor of Cardiology in the Cardiac Center, Bahawalpur, Pakistan. I am thankful for the Young International Academy of Cardiology for inviting me to give a talk on this topic. My topic is novel pharmacological management in patients with systolic heart failure. So, first, briefly going through the background. What is the rationale of this topic? As we all know, systolic heart failure carries a very high mortality in the short as well as in the long term. And according to the Framingham Heart Study, the 5-year mortality is more than 60%. And in males, it is around 75%. So it is very high. It is even more than some of the very common cancers like prostate cancers and lymphoma and breast cancer. And this is the rationale of ongoing research to develop the new drugs, especially pharmacological, to reduce this mortality. So what are the treatment options available for the heart failure? We broadly divide it into 4 categories. For is pharmacological, device therapy, and we can use the left ventricular assisted devices or mechanical circulatory support. And finally, in very advanced cases, there is option of heart transplantation. So what are the pharmacological management we can use in patients with systolic heart failure? Apart from the therapy, which is given for the underlying disease, the specific therapy for the heart failure can be divided into the conventional or the historical group, which include ACE inhibitors or ARBs, beta blockers, and mineralocorticoid receptor antagonists. And all of these 3 drugs have shown to reduce the mortality in different clinical trials and these are well-established therapies for the patient with systolic heart failure. And what we can say, what are the novel therapies which has come in the last decade, which have also proven and have shown to decrease the mortality in these patients and systolic heart failure, and which are now coming in the guidelines. So these novel therapies are pharmacological therapies are avapradine, Harni, which is a combination of sacubitril and valsartan, and SGLT2 inhibitors, which is sodium glucose transport inhibitors too. So I will start from a scenario. It is a very common scenario, at least in my clinical practice, and you have all have come receive these kinds of patients in your OPDs or clinics. So it's 75 years old gentleman who is smoker for last 30 years. He has advanced COPD and has a prior anterior wall MI, and due to that he has ischemic cardiomyopathy and ejection fraction is around 30%. He is very short of breath and function class 3. His blood pressure is very borderline, always like in the 90 by 60 millimeters of mercury range. His tachycardic, heart rate is 114 per minute, and sometimes he complains of postural dizziness, especially when he stands up from the sitting position. He is already on low dose of ACE inhibitors and diuretics and other drugs. So my question is, what drug modification we can do in this patient to improve his symptoms? Do we want to increase the diuretic? Yes, he is symptomatic. We want to increase this. Can we add beta blockers in this patient? No, it's not a very good choice, as the patient is having an advanced COPD and already having postural dizziness. So then we may encounter difficulties while prescribing these drugs. Can we increase the dose of ACE inhibitors? Yeah, we can increase, but again, the blood pressure is borderline, and we all know when we increase the dose of ACE inhibitors along with the diuretic, it can increase the postural symptoms. And the fourth option is increase the dose of diuretic and add avapradine. So this 4 option is more practical in this scenario. In a patient with advanced COPD, tachycardic, having postural dizziness, already tolerating ACE inhibitors at low doses. So this is the best option in this patient to increase the dose of diuretic to improve the symptoms, and add avapradine to reduce his heart rate and again improve his symptoms, because of reduction in the heart rate can have effects on prognosis as well. We will discuss. So coming to the avapradine, a short overview. It is a sinoatrial nodal blocker drug. It has a negative chronotropic effect on the heart. It reduces the heart rate. but it has got no other hemodynamic effects like effects on the blood pressure. It has no effect on the AV node, so no problem to give in patients who have conduction system disease, especially at the AV node level, and it has no negative inotropic effects on the myocardium as well. So as far as the drug is concerned, it acts only on the SA node and decreases the heart rate. So it is a brief illustration of the mechanism of action of the ivabradine. This drug acts on the so-called funny channels, which blocks the entry of sodium into the myocardial cells in the SA node. And again, the potassium concentration inside the cell becomes more because it's sodium potassium exchange channel. As a result of this, the diastolic slope is further slowed down and the heart rate decreases. So coming to the trial of ivabradine, a beautiful trial is conducted in 2010, presented in the ESC, and with the name of SHIFT. This is the systolic heart failure treatment with ivabradine. So ivabradine is used as a selective inhibitor of sodium potassium channel, and more than 6,500 patients were conducted in the studies. All were symptomatic and had systolic LV dysfunction. All were tachycardic. Heart rate resting was more than 70 beats per minute, and all have a history of hospital admission in the last year. The primary outcome was composite of cardiovascular death and heart failure hospitalization. So this was the result of the SHIFT trial, and we saw a 24% reduction in the heart failure hospitalization and the mortality. So ivabradine was very effective in reducing the mortality in patients with systolic heart failure by just reducing the heart rate. And this translates into the guideline endorsement by the European Society of Cardiology, American Heart Association. Ivabradine can be beneficial in patients with reduced heart failure hospitalization for the patient with symptomatic heart failure and ejection fraction less than 30% who are receiving guideline-directed evidence-based medication, including a beta blocker at the tolerated doses, and who are in sinus rhythm and heart rate of more than 70 beats per minute or greater. So it is a reasonable choice to give in patients of heart failure with systolic dysfunction who are tachycardic, and when other choices, especially when other choices are very limited, and it has shown to decrease the mortality. Now coming to our second drug, which is ARNI, and it is a combination of two drugs, sacubitril and valsartan. So what is sacubitril? It is a neprilysin inhibitor. When it inhibits this enzyme neprilysin, which actually degrades the natriuretic peptides in the body, the concentration of these natriuretic peptides increases in the body. As a result, when the concentration of these natriuretic peptide increases in the body, vasodilatation occurs, and as well as inhibition of fibrosis, and there is suppression of aldosterone system. But when we give sacubitril, the concentration of other agents rises. To block these agents, especially angiotensin 2, we give valsartan, which is a renin-angiotensin aldosterone system inhibitor. And we all know the favorable effects of giving valsartan. Sodium and water retention decreases, vasoconstriction is inhibited, and effects on the hypertrophic fibrosis are well established. So this combination, and this is the landmark trial which comes in 2003 and published in European Heart Journal and the New England Journal of Medicine as well. And Paradigm HF trial, it is a multi-center trial. It compares the sacubitril valsartan with the enalapril. Enalapril was given in a dose of 10 milligram BID. The trial was conducted and the outcome was seen at about 30 to 32 months, which is a quite enough period. The sacubitril valsartan dose was gradually increased to 200 milligrams PD. The primary outcome was again to see the cardiovascular mortality and heart failure hospitalizations. So the secondary outcome was all-cause mortality, renal progression, and other effects. So this was the results of Paradigm HF trial. The ARNI has shown significant reduction in the primary outcome of heart failure hospitalizations and the cardiovascular death. So this is very popular drug nowadays, and the evidence was so strong that the guideline endorsement immediately came out, and which says that in a patient who have a systolic heart failure, the clinical strategy of inhibition of renin-angiotensin system with ACE inhibitors or ARBs or ARNI is now stands in class 1 indication when the patient is already on receiving the beta blocker therapy. So, guideline endorsement further came out that in patients who are already receiving and tolerating ACE inhibitors and ARBs, we can even replace the ARBs and ACE inhibitors with the ARNI to further reduce the morbidity and mortality in this patient. Now coming to the third drug, which is SGLT2 inhibitor. It is a basically anti-diabetic drug. It works in the proximal tubules of the kidney by blocking the resorption of the blood glucose. So the glucose is secreted into the urine. These are the mechanism of actions of the SGLT2 inhibitors and its cardiac effects. When it inhibits the absorption of glucose, the glucose concentration in the urine rises and it decreases the natriuresis, diuresis, and which decreases the systolic blood pressure, arterial stiffness, plasma volume, and hemodynamic effects are favorable for the heart. So this trial came out last year, 2019, in the ESC, and with the name of DAPA-HF trial, and it compares dapagliflozin in a dose of 10 milligram daily with the placebo. And the primary outcome again was cardiovascular death and heart failure hospitalizations, and it showed a significant reduction in the heart failure hospitalization and cardiovascular death as compared to the placebo. And this trial just came out in the current ESC in the 2020 with the name of Emperor Reduce trial, and again comparing this the same class of drug empagliflozin in patient with heart failure with reduced hospitalization. And empagliflozin again has shown that in patients who have ejection fraction less than 40%, it reduces cardiovascular death and heart failure hospitalization as compared to placebo. And this effect was produced regardless of the presence of diabetes, whether the patient is having diabetes or not, and the patient was watched for over a period of 16 months. So this new class of drug has also been shown to reduce the mortality and heart failure hospitalization in this group of patients. So as far as the guideline endorsement is concerned, for this class of drug, they're still awaited, and the evidence is coming so strong that it may be in the guidelines we see in the future. Thank you, all of you, and have a nice day. Thank you very much.
Dear Dr. Nauman, I thank you very much for amazing presentation. Thank you very much. You talked about the top novel drugs regarding the ivabradine and sacubitril/valsartan, and also regarding the gliflozins, which is very brand new. Thank you very much. Dr. Fady, do you have any questions or comments regarding the presentation?
Yeah, thank you, Yasmin. Actually, it was a pretty outstanding lecture, Dr. Nauman. I completely agree with Yasmin. I just have one a bit of question, which is actually sometimes more like it's a bit of common right nowadays regarding patients with HFrEF and AF. And the thing that you've mentioned kindly in the beginning of your presentation about those patients, which thing you'll prefer really to add on top of his therapy already, which is whether you will add beta blockers, diuretic. It was already in NIHA class 3. So whether you will add diuretic or beta blocker or ACE inhibitor or whatsoever. But I was just thinking of one thing. Have you ever considered in those kind of patients who are not on SGLT2 inhibitors to consider them for those patients who needs more diuretic to add SGLT inhibitors, because anyway it has a diuretic effect like empagliflozin, dapagliflozin. We've known through the whole trials of both EMPA-REG and DAPA heart failure and all those that they have, plus their amazing rate of reduced hospitalization for heart failure and reduction of symptoms and improvement of survival. But the thing that it's also having a diuretic effect. So would you consider in this kind of patients who needs up titration of diuretic to add something like that, the SGLT2 inhibitor?
Yeah, Fady, you raised a very valid point, and this is the ideal group of patients which needs the addition of this newer SGLT2 inhibitor drugs. because these drugs increase the diuresis, and as they help in relieving the congestive symptoms, they also have effect on prognosis, as we have latest evidence from the Emperor Reduced trial and the DAPA-HF. So this is the ideal kind of group. However, you have to look for to see the like effect on the urinary tract infections, and you have to look care for the electrolytes and of the patient, and you have to also look for the like volume status of the patient have to be keep in mind. So the newer evidence also suggests that the addition of this drug does not like depend on whether the patient is having diabetes or not. So these patients, these drugs can be added in this group of patients. Yes, this is very valid. Thank you.
Wonderful. Thank you. Thank you very much. Dear Yasmin, do we have any questions from the audience so far?
And no, unfortunately, we don't have any other questions, and I think we can switch to another presenter, which is Dr. Sarah Moharem Elgemal, which is my very good friend from Zurich University, the specialist of heart failure and a very good specialist in cardiac magnetic resonance. And Dr. Sarah is going to talk about the role of CMR in heart failure. Please, Dr. Sarah.
Hello, my name is Sarah Moharem Elgemal, and I'm a cardiologist at the Liverpool Heart and Chest Hospital and at the National Heart Institute. I am delighted to be invited by the organizing committee to discuss the role of CMR in heart failure. I have no disclosures. On the agenda today, I plan to discuss what's the usefulness of CMR in assessment of heart failure. So why CMR in assessment of etiology, management, and prognosis? I will briefly touch base on each because of the constraints of time. So CMR, because of its excellent capability in assessing cardiac morphology and tissue characterization, as well as being the gold standard for assessment of LV and RV function, was granted Class 1 level of evidence C in the ESC guidelines, and this is commonly used in our everyday practice when assessing patients for heart failure. It is also allows us to differentiate through gadolinium enhancement ischemic and non-ischemic etiology by identifying the patterns of fibrosis in patients who are thought to have or been labeled as dilated cardiomyopathy, and this has been given a Class 2A level of evidence C. And in the assessment of, to assess the presence of inducible ischemia and viability through stress CMR and through late gadolinium images, which has been granted a Class 2B level of evidence B on the guidelines. So CMR allows us an unrestricted field of view with a lack of radiation. It allows us to assess cardiac function, as I previously discussed, the cardiac morphology, to assess myocardium, valves, different chambers, sizes, and different tissue characterization sequences like native T1 mapping used to assess for interstitial fibrosis, T2 stir images, and T2 mapping, which are sequences that can be used to assess for presence of myocardial edema. The use of flow imaging to assess the valves and congenital heart disease when these are the suspected etiology of heart failure in our patient, and the role of stress CMR to assess what is this, if we suspect the patient to be ischemic, to assess what is the ischemic burden and to guide management, as well in post-myocardial infarction risk stratification, whether other vessels need to be treated after having gone primary PCI to assess the presence of microvascular occlusion, as well as to assess in patients the presence of any thrombi and the extent of myocardial infarct burden, particularly in patients with chronic myocardial infarction. So cardiac MRI allows us through the cine images in which we can obtain a stack across the LV and the RV, a short axis stack, in which we do multi-slice summation, in which we contour the endocardial borders of and diastole and systole to obtain the volumes in these prospective phases and obtain ejection fraction. Through cine images and through multiple vendors now that have created a feature tracking software that we can use to assess strain. And there is another sequence called myocardial tagging in which we can also assess strain. And this is actually the gold standard in which speckle tracking has been compared to for the assessment of strain. Echocardiography can also assess for transmitral blood flow velocities, myocardial tissue velocities through flow, and the assessment of pulmonary artery pressure to assess the pulmonary artery vortices and left atrial dimensions. The cardiac MRI allows us also, this is an example in which different etiology, in which we can see dilated left ventricles, enlarged chambers, the distribution of hypertrophy in HCM, presence of LVOT obstruction as seen in signal voids, patchy delayed enhancement. We can also depict non-compacted myocardium that might not be adequately visualized in echo, as well as the presence of failure to null late gadolinium enhancement images with amyloid. On late gadolinium enhancement images, there's certain patterns of late myocardial enhancement in which we see with ischemia, subendocardial or transmural, and ischemic, we can see mid-wall epicardia or global. And in patients with ischemic heart disease who have had a recent myocardial infarction, have gone primary PCI, we can see in these patients microvascular occlusion as seen in the early late gadolinium enhancement images here and the late gadolinium enhancement here, in which you see a hypodense area within an infarcted region. And this is the quite characteristic appearance for microvascular occlusions or MVOs. And regardless whether this has been associated with reflow or non-reflow, these patients have a worse outcome in comparison to their counterparts that had no microvascular occlusion on post after having a CMR post-infarct. Cardiac MRI late gadolinium enhancement allows us to assess replacement fibrosis and scarring, but it doesn't allow us to assess the reactive interstitial fibrosis as seen in hypertensive heart disease, valvular heart disease, as well as the infiltration of infiltrative interstitial disorders as amyloid and Anderson-Fabry. And certain sequences like T1 mapping, in which we use to assess the extracellular volume, and to assess extracellular volume allows us to assess for the presence of diffuse fibrosis or interstitial fibrosis in the absence of late gadolinium enhancement. So parametric mapping techniques, as we hear different examples of different etiologies of which we can see here in patients that present with amyloid and with myocarditis have increased T1 value mapping values, and in patients who have fat deposition, iron deposition as Fabry's and iron hemosidrosis will show decreased values. And in T2 mapping, increased values will be seen on patients who exhibit myocarditis. And this, the EuroCMR registry and the results that were published in JCMR 2013, in which 15 nations were looked at, 57 centers in 15 nations were looked at, in which over 27,000 patients. And CMR had an important role in being able to identify a new diagnosis in this patients, and to a change of management in 52% of these patients, whether this could have been a change in medication, invasive procedure, hospital discharge, and admission. These patients, of course, weren't just heart failure patients, but they were also patients of different etiologies. But this shows the importance of the impact of CMR in our practice. Cardiac MRI, as we know, the presence of fibrosis has important impact on the prognosis of our patients who have non-ischemic dilated cardiomyopathy, not just an ischemic cardiomyopathy, as published by Glatt in 2013, whether as regards all-cause mortality, cardiovascular mortality, transplant, heart failure, and sudden cardiac death. In patients who have undergone heart transplants, the use of myocardial perfusion reserve has been shown that in patients that it is able to predict independently coronary allograft vasculopathy in epicardial and in microvascular compartments, as seen in this study by Miller, and in another study of 108 patients in Hoffman, the myocardial perfusion reserve, the change over time corresponded with, mirrored the progression of the coronary allograft vasculopathy seen in these transplant recipients. So cardiac MRI also has a role in the assessment of amyloid. The use of T1 mapping could depict amyloid deposition even prior to the overt picture of amyloids, which we see with the failure to null on the late gadolinium enhancement images. Extracellular volume fraction in patients with amyloid, the T1 mapping values increase in these patients, and it increases more with the burden of the amyloid in the extracellular space. In patients who have light chain amyloidosis, an extracellular volume of greater than 0.45 had a bad prognosis in these patients. So to wrap it up, cardiac MRI can aid in the diagnosis of heart failure. It can provide a specific diagnosis on a substantial proportion of heart failure patients and enables the selection of best management strategy. It allows us to identify prognostic markers in heart failure with ischemic and non-ischemic etiology, and allows us to monitor therapy and disease progression. Thank you for your time.
Dear Sarah, thank you very much for the outstanding lecture. I personally find it quite educational. For example, for people who doesn't have much experience with the CMR as well. I will leave the panel of discussion for Dr. Yasmin for commenting on the lecture, or in case any audience questions. Since Dr. Yasmin already, she's a CMR expert. We all know that. So Yasmin, please, you can go ahead.
Dr. Fady, thank you very much for a nice presentation. I think that CMR is really crucial in the diagnosis of heart failure. Of course, we can, when we do an echo, we can see and easily make a diagnosis on dilated cardiomyopathy. But if you want really to know the prognosis of patients, and we all know that now the extent of LGE, it means that the extent of fibrosis plays the crucial role for an maybe indication, especially for a primary indication for ICD. And of course, when we have a HFpEF patients, is sometimes when the patient is hypertrophic, it's really very difficult to make a diagnosis using only echo. And the CMR helps us to differentiate the different types of hypertrophic heart. And we can see the amyloid, the Fabry disease, and we can also make totally change the treatment of the patients. So I think, and of course, now we are using the novel techniques of CMR, not only with the contrast media, but also the novel techniques which Dr. Sarah presented us, the T1 mapping, and also we can measure the extracellular volume and see not only the focal fibrosis, but also interstitial fibrosis, which is also very helpful to make a diagnosis and prognosis for heart failure patients. So I think that from now everyone understands the importance and the crucial role of CMR in the diagnosis of heart failure. And I really thank very much Dr. Sarah for amazing presentation. I think it was useful, and also for me, very nice presentation.
Yeah, I couldn't agree more, Yasmin. And we are sorry, Dr. Sarah, she had to leave for emergency. She's on duty and she had an emergency call. So she left us with her amazing lecture to enjoy it. And then she had to leave, but it's great. It's very good what you have mentioned, dear Yasmin. My dear speakers, we are very pleased really that you are on board. And I think we have 2 minutes till the end of the session. Would you like to have any points of discussion, dear Dr. Nauman, Dr. Alexander, before we wrap? Yes, please go ahead.
I have to say that, for example, when we speak of CMR, we have to be very pragmatic. And again, we have to select the patients undergoing CMR, because in my country, we have like 150,000 people with heart failure. And we have 2 or 3 CMR centers. So you imagine if we have to scan them all, the centers will have to work the next decades, 24 hours per day. And they will still not be able to manage scanning all these patients, because there will be new patients coming. It's the same with PVI. We have another 140,000 patients with AFib in my country. Can we PVI them all? No, we can't do radiofrequency ablation in all of them. So we need to have very strict and very pragmatic criteria. Whom do we send for RFA, for PVI? Whom do we send for CMR? And it has to change either how the patient feels, or the outcomes, or the diagnosis. Otherwise, just to confirm what we feel, or to send the patient for RFA and then for the patient to come back and not to be in sinus, this is pointless. This is waste of resources, and we don't have enough resources. So we have to be very careful with that. What is the clinical utility of any technique that we use?
You're absolutely right. May I ask you a question, please, Dr. Fady, if you allow me to ask a question? Dr. Nossikoff, what do you think? Will CMR be useful for you, as you talk about the AF, for the selection of AF patient, for the selection of for ablation? So do you think the CMR could be somehow useful in terms of fibrosis, whether we are talking about the fibrosis of left ventricle or maybe right, or maybe left?
I think so, because there are 3 ways to assess atrial fibrosis. So one way is to do left atrial strain. The other way is to do CMR with LGE of the atria. And the third way is to do the electrophysiological map. So this is one of the ways before you go to the electrophysiological map to have an assessment how much fibrosis do you have in the atrium.
Okay, thank you.
Perfect. Yasmin, I think we have one question from a respected audience. Can CMR identify the different causes of myocardial ischemia patterns, like in coronary spasm, for example?
In CMR?
Yes, can CMR identify the different causes of myocardial ischemia patterns, like in coronary spasm?
I mean that in CMR, we don't use for everyday practice to see the coronary arteries using the CMR. So I think if we have an ischemia in CMR, we can only answer whether we have the perfusion defect or not. But whether this perfusion defect is caused by really atherosclerotic process, but spasm, we can't see it. So
I agree. It would be a bit tricky, actually, for the CMR to detect spasm. And another last question before we wrap up and end up this session. How would the effectiveness of CMR in the assessment of cardiac pressure gradients as compared to echocardiography?
My personal opinion is that as the CMR is not live, so I think whether it's live is, like echo is better. Of course, using by CMR, we can calculate the flows, etc. In the terms of calculation of regurgitant volume, sometimes the CMR is better. Yeah, but to be honest, to be very practical, I would prefer to do an echo. So when you have a very good echo specialist, valve disease is for echo, I think. What do you think, Dr. Nossikoff? Are you agree or?
I think sometimes you have cases that are not clear cut. For example, you don't catch the best gradients through aortic valve or whatever. But I agree with you that it's best for regurgitant lesions where you are wondering, is this moderate or severe, and you are not sure. So when it's a borderline case and you need something else to have a decision, maybe you can do a CMI to see what will come out.
Maybe, but generally echo is preferable.
Yes.
Yeah. Okay.
Eventually, you will have to use cardiac cath for some cases.
Oh, yeah. You're right. Yes.
Actual cardiac pressures measurement. Yeah. Thank you very much. I really appreciate. I'm very sorry that we have to end up this session. It's very interesting being with you, and I'm very pleased to have you all on board. Amazing speakers. Thanks a lot, Yasmin, for your great help. You were able to discuss with us a lot of CMR things we're not so much aware of. Thanks for the audience. Please stay with us. We have the next session. It will be a very interesting session by the title Cardiology and Comorbidities Beneath the Iceberg. It will be chaired by my dear Professor Mehdi Zogdi and my dear friend Dr. Nigar Babazad. Stay with us. Thank you very much.
Thank you. Bye-bye.
Bye.